I'm Morgan Craven, Director of Programs and Events for Farm Foundation. Thank you for joining us today for the Farm Foundation Forum, The Healing Plate, Food, Health, and Agricultural Innovation. We're glad to be able to engage with you and are thankful to Farm Credit for their support of this forum. I'm looking forward to today's discussion, where we explore the potentially transformative food as health movement and its profound implications for healthcare providers, consumers, policymakers, and farmers. The connection between food and health has moved beyond talk of what is healthy to a broader movement that has the potential to reshape the food, healthcare, and policy landscapes. The food as health movement is built on the principle that food is not just fuel. It is medicine, capable of preventing, managing, and even reversing chronic diseases. This should be a great discussion. Before we get into today's forum, I'm going to take just a few moments to share a bit more about Farm Foundation. We are a 501c3 nonprofit working at the intersection of agriculture and society to address challenges that affect the entire food and ag value chain. Specifically, we are an accelerator of practical solutions for agriculture, accelerating people and ideas into action. The three levers we use to accomplish this are policy, innovation, and education. Forums such as today's are just one part of our extensive program of work, which is guided by our mission to build trust and understanding at the intersections of agriculture and society, and our vision to build a future for farmers, our communities, and our world. We rely on partnerships and coalitions to fund our work and increase our impact. So if you're interested in learning more about partnering with us, I encourage you to reach out. Now, I'd like to take a minute to highlight our Friends of Farm Foundation program. With your enrollment as a friend, you will not only be helping to support the mission and vision of Farm Foundation, but you will also gain exclusive benefits, such as first reads of our issue reports, networking opportunities, and much more. Being a friend is an investment in building a better future for farmers, our communities, and our world. To learn more about being a friend of Farm Foundation, go to farmfoundation.org/friends. The link is also being posted in the chat. In addition to learning more about Farm Foundation and our work by visiting our website, I encourage you to connect with us on our social media platforms. If you are posting on social media about this morning's session, we ask that you please use the hashtag #FarmFoundationForum. And before I hand the floor over to our moderator today, here are the last few housekeeping notes. There will be an audience question and answer session at the end. We'll be using the Q&A button at the bottom of your screen, not the chat, to cue the questions. This forum is being recorded and will be posted on our website at farmfoundation.org, as well as our YouTube channel. We'll send out that link following today's program. When the forum concludes, you will receive a link to a brief survey. Farm Foundation appreciates your feedback and your time in completing the survey. Now let's turn to today's forum. Today's panel of experts will be moderated by Craig Gunderson. Craig is the SNE Family Endowed Chair and a professor in the Department of Economics at Baylor University. He is also the creator of Feeding America's MAP, the Meal Gap Project, a roundtable fellow of the Farm Foundation, and a faculty affiliate of the Wilson Sheehan Lab for Economic Opportunities at the University of Notre Dame. His research concentrates on the causes and consequences of food insecurity and on the evaluation of food assistance programs, with an emphasis on SNAP. In addition, Gunderson is a fellow of the Agricultural and Applied Economics Association, AAEA. Thank you for moderating today's panel, Craig. I'll let you take it from here.
Okay, great. Okay, thank you, Morgan. It really is an honor to be the moderator of this. I'm very excited about it. I wanted to begin by thanking Farm Foundation and Farm Credit for hosting this, and for the four exciting presenters we're going to have today. But I also want to thank all of you. There's a lot of other things you could be doing this morning rather than this. So I really appreciate you all being a part of this conversation. So just a bit of background here. I mean, as you're all well aware, the past 100 years, there's just been incredible growth in the agricultural sector. This has both been, across farms and ranches across the United States, but globally, whether it be in Brazil, whether it be in Tanzania, whether it be in India, all across the world. There's an amazing increase in agricultural productivity. And this is due to things like, for example, the Green Revolution that Norman Borlaug started, but also like more recent things like the introduction of genetically GMOs. GMOs did a remarkable job at transforming agriculture. And along with this incredible transformation, the productivity of agriculture is that we also have this incredible distribution system. We're able to get food all around the world. And this has just led to amazing things. And probably the most important thing that's this led to is this really pretty dramatic decline in undernutrition and declines in food insecurity across the globe. I think we should really recognize and be really happy with all that this has done. Put this differently, is that billions of people around the world are now able to afford safe, affordable, and nutritious food. And in thinking about this, is that one of the things that I really want to emphasize about all this is the critical role of our land grant institutions across the United States. I know a number of you on at this meeting today are at our land grants. I had the honor of used to be at the land grants, whether it be at University of Illinois and before that Iowa State. Very fond of it. And all these things would not have occurred without our wonderful land grant institutions. I also want to praise the Farm Foundation. You've been at the front of echoing all these different productivity advances. So really credit to the Farm Foundation. But one thing I want to talk a little bit about is just the incredibly importance of food for enjoyment and for our culture and for bringing communities together. And I like to talk about like Wisconsin. I'm from Wisconsin, and our lives in the summer, we enjoy getting together. And one of the things that's central to us getting together is brats. The way I cook my brats is I let them simmer. It's a Miller High Life, some water, Miller High Life mainly, but some water as well. Cut up some Vidalia onions, put them, let it simmer for about 3 hours on low heat. So you get these incredible brats. You slap them on the grill for just 30 seconds on each side. It's wonderful. All across Wisconsin, that's what we're doing over the summertime. But now I live in the great state of Texas. And in particular, I live in Houston. And Houston, we have one of the most vibrant and exciting restaurant scenes in the United States, nay, the world. And it's just incredible to be here and experience all of this. It's another part of us getting together, enjoying food and everything. Now, something else that has emerged that we're going to be talking about is that we're going to be talking about today is this notion about food as health. Okay, and we're talking about this is, of course, my brats that I make, I don't think they fall into this, nor 95% of what's consumed at these Houston restaurants, bringing families and everybody together. But food as health has become a major component, as what Morgan has talked about. So this is going to be exciting today to listen to all this, but it's also a really exciting time for the food as health thing. The Trump administration has really bought into this big time. It started out with this MAHA movement, and everything else really has done this. And the Trump administration has made a number of changes. I mean, the Secretary of HHS is a big proponent of this food as health. And also, the new appointee to being the Surgeon General that Trump has appointed her is that she's also a big proponent of this food as health. So opportunities like this that the Trump administration is giving, what these four speakers will be talking about, really hasn't been seen before. So this is pretty exciting. And also is, across the country, as state legislatures, predominantly in Republican states, have been proposing a lot of proposals along these lines as food as medicine. So at any rate, so that kind of gave us a bit of a background about why this is going to be so exciting today, but also how this builds. I think we can't forget how amazing our agricultural sector is. And praise to all the farmers and ranchers and everybody, the truckers and everything, bring it to those working in our grocery stores. We can't forget all those amazing people doing all this excellent work. Okay, now what we want to do is we want to turn it over to the speakers. So enough of me. Okay, I would like to start off the conversation with our first panelist, Erin Martin. Erin is a gerontologist and founder of and CEO of Fresh RX Oklahoma, a nonprofit focusing on improving health outcomes through access to nutrient-dense, locally grown food. A certified regenerative soil advocate, she's a champion of the, as quote, here's food as medicine movement, emphasizing the link between nutrition, chronic disease prevention, and soil health. Erin's work is grounded in both personal experience and professional insight, making her a powerful voice and reimagining how food and healthcare intersect. Erin, take it away. We look forward to what you have to say.
Thank you so much, Craig. It's so nice to meet all of you. Like Craig said, I'm the founder of Fresh RX Oklahoma. It was founded in 2021 in a food desert area in North Tulsa, Oklahoma, where we have the highest rates of mortality from diabetes, with a community without a grocery store for 14 years. So I'm really excited to share how we've become touted as a very innovative program, and I'll share those key points during my presentation. You can go to the next slide. So just a little bit background on me. I started working in long-term care when I was 15 years old. I was very passionate about older adults and people's dignity to age well and have quality of life. I worked in all levels of long-term care until I was about 25 years old. I was director of social services over 7 affordable housing sites for seniors while I was getting my master's in gerontology from the #1 school of gerontology in the world at USC. And I saw people on 15 to 32 prescription drugs at a time. But I was learning in school the natural part of aging is not disease. There's actually places in the world where people die of something called old age on 0 prescription drugs. And I went over to Italy and studied death and dying and quality of life and nutrition over in Italy. And shortly after, I hooked up with Kiss the Ground, a nonprofit that talks about soil health, and quickly connected nutrient density, soil health practices to health outcomes, and helped people for years change their lifestyle and even come off all of their prescription drugs, and watch people do that for themselves. So it was really exciting to move back to my hometown and to be able to launch this program in tandem with doctors and farmers. So go to the next slide, please. So I just want to get a little bit of overview of what food as medicine programs are, just to set the stage for some of my fellow speakers today. The top 3 parts of this pyramid are what we refer to as the food as medicine space. So they're just different ways of providing food to people with chronic disease, particularly those with food insecurity. A lot of states are passing something called, or including food as medicine in their 1115 Medicaid waivers, so that people who are low income, this is actually becoming a reimbursable program. So produce prescription is that one there, the first one. That's more what we are. It's whole fruits and vegetables that we're prescribing to people with type 2 diabetes. Then medically tailored grocery is a little bit broader. It would include other products like meat and dairy and eggs and things like that, but medically tailored for their chronic disease. And then at the very top is medically tailored meals. Those are pre-made meals, typically prescribed to people for 90 days right out of the hospital, or otherwise for chronic disease management and prevention and even reversal. So those are kind of how those programs are. They started really through the USDA. There's a fund. We were funded through the GusNet program in 2022. A lot of them are farmers market based for vouchers for people with food insecurity. And some programs are now elevating that to measuring health outcomes. And we're seeing really amazing things. And so the Farm Bill's been kind of footing this bill for healthcare for a long time. And now we're trying to get healthcare to pay for it. So some programs are now billing insurance. And I'll talk more about where we are with that in a minute. So go ahead to the next slide. So this is Dr. Kent Farish. He came forward from North Tulsa to a community committee, and he said, my patients are compliant with their medications, they're compliant with their doctor's visits, but they're getting worse, and it's the food, and I want to prescribe food, and can you help me do that? And I said, absolutely. So we launched with 52 patients in 2021. I fundraised over Zoom for 4 months during the pandemic and raised $185,000 to start with 52 patients. We've quadrupled in size. We've served over 400 patients since 2021. And we also now serve the Muskogee Creek Nation's produce prescription program as well. You can go to the next slide. This is our team. It's fast growing. It was just me in 2021. I realized we needed a lot more folks. So we have some enrollment coordinators. We have an education coordinator. We have produce coordinators. We have a director, Julie, to my right in this photo. And what's really key is that my team reflects and walks the walk of our community. So several people on our team have lost 100 pounds individually and reversed their own diabetes. And even Deborah, who's in this photo, she actually went through our program and now she enrolls people in our program. And I think this is really important that programs are not cookie cutter. They can be a blueprint, but they need to be customized and relatable to the community. And people need to trust the people that are providing these services. Go to the next. And these are our farmers. When Dr. Ferris said, I want you to do this program, the committee was like, well, we'll just get the food from Walmart or Amazon. And I was like, I don't think so. I think we should get it from all local food, keep the money in our community, and find all regenerative growers, because I knew how much more nutrients was in that food. And people said there's no way you could do it. And so I had fun proving everyone wrong. We serve people every week, year round, and we've helped scale these growers dramatically. And it takes a village and a community. So we've really created community around this program. Go to the next slide. So I just wanted to show this briefly. We don't have a ton of time to go into it, but there's certainly lots of resources out there. There's lots of people doing studies. More and more will be proven. But Bionutrient Association really proved that not all fruits and vegetables are created equal. And the ones that have more nutrients typically are using good soil health practices. There's 6 principles of regenerative agriculture. If you don't know much about that, you can watch Kiss the Ground or Common Ground on Amazon Prime. What was really starking is just being local is really key, especially for fruits and vegetables that lose 30 to 50% of their nutrients within 72 hours. You can see here on the right, this is from David Montgomery's book, What Your Food Ate, and you can see the comparative analysis there. Go ahead and go to the next. So the nuts and bolts of our program is people are enrolled. We get a referral from 22 primary care clinics across 6 health systems now in Tulsa. They get about a $50 worth of fruits and vegetables. It's in an open crate style for people that come to pick up. They go to a class, they get their food, and they are required to go to 2 out of at least 6 opportunities of classes. We have a hybrid model where people can get delivery or pick up. They get about $50 worth of produce every other week for an entire year for free. Food is a teaching tool to help them try new things and be able to know where they can purchase those and how they can use their resources to access the same incredible quality food. And then we do health metric checkpoints every 3 months. We measure A1C, weight, and blood pressure and collect all that data. We do some pre-post surveys as well for additional qualitative surveys, and looking at improvement in mental health, pain, correlating increased consumption of fruits and vegetables with the improvement of overall health. And we've seen a drastic decrease, statistically significant, of people decreasing their consumption of soda as well. Go to the next. This is a little bit of how that works. We get the enrollment, we screen them for readiness. So we're making sure these people know this is not a food giveaway program. This is a healthcare intervention. We screen them, we give them a starter kit, we get their initial baseline metrics, and then they go into the program. We track all of this through a customized CRM that we actually just developed and launched because spreadsheet was not manageable. And needed to be HIPAA compliant to start engaging with these healthcare payers. And so we really track participant engagement, and they have to be committed to this. Go to the next slide. This is some of our outcomes. This is from our 3rd year, so our 4th year is still under evaluation, but this gives you an idea that the lady who lost 116 pounds last year actually now lost 132 pounds. She fully reversed her type 2 diabetes in 8 months, came off all of her prescription drugs. And this is someone who was on drugs and had diabetes for 10 years, and we reversed it in 8 months. So we think now with over 400 patients, we've saved the state of Oklahoma $5 million in healthcare costs. this is a 5 times ROI of what the cost of the program is. So this is a sustainable business model that should be fully integrated into healthcare. So we're hoping this will be federalized with the leadership like Craig was talking about. We are the MAHA poster child, as we like to say, but we would like to see some dollars put into these programs nationwide. Go to the next. We had a cost savings benefit analysis done with an actuary firm. They took actual claims data from our state Medicaid in Oklahoma, and we have 118,000 type 2 diabetics on state Medicaid. They said if we had a 5% penetration, which would be about 5,900 people, we could save the state up to $28.5 million in healthcare costs. They used very conservative methodology, so I think there's a lot more to be had there. But the actuary firms are supposed to be conservative, so this is great. This has been a great tool for us and our Food as Medicine Policy Coalition to further change in our state. If you go to the next. And so it's really important that these programs are fully aligned all the way to the farmer. The farmer should be getting paid well. They should be aligned in this financial model when contracting with health payers. So we actually got our first healthcare contract last year. It's a value-based care arrangement. So they're not just paying for food, they're paying for a full healthcare integration they pay for the full program, the food, education, and the patient support. And we get a price per month per patient plus bonus payments. And it is my dream with those bonus payments that goes back as dividends to the pharmacists. So the farmers who are really the pharmacists to get benefits and be paid for the health outcomes that they're the ones actually producing by the way that they're growing. So that's my big, hairy, audacious goal. Go to the next and I'll wrap up soon, Craig. Thanks for the time there. Food as Medicine Act was passed about a week and a half ago in Oklahoma. So this basically makes it law for state Medicaid to be paying for these types of programs. This means we'd have an ability to be sustainable and scale in our state. We're super excited. Governor Stitt actually did just sign it on Friday last week. So it is the law in Oklahoma, and we're really proud about this. Go to the next. And if you'd like to learn more about me, you can go to erinwmartin.com, scan this QR code. I made a Food as Medicine resource guide. If you're interested on how to get connected to programs or want to start your own, you can also book one-on-ones with me. And I help programs all over the world, actually help set one up in the Netherlands. I oversee one in the Mississippi Delta, and I just launched one in Illinois. So very excited to help this model spread like wildfire. Thank you all for what you do and for listening today.
Thank you, Erin, and thank you so much for staying strictly on time for this. I really appreciate it. So one thing I should note is if any of you all have questions, please be free you can put them in at the end, but you can also put them in throughout as questions emerge. So please put those into the Q&A, and I'll accumulate them and ask them later. So our next speaker is David Katz. David is a specialist in internal medicine, preventive medicine, and lifestyle medicine with deep expertise in nutrition. He founded Yale University's Yale Griffin Prevention Research Center and is past president of the American College of Lifestyle Medicine. He's also the founder of the True Health Initiative and serves as chief medical officer at Tangelo, a food as medicine company. David holds degrees from Dartmouth, Albert Einstein College of Medicine, and Yale School of Public Health. Thank you, David, for joining us today.
Thank you, Craig, and thank you, Morgan. My pleasure. Nice to be here. Good morning, everybody. In the next little while, I just want to make the case for food as medicine. Why is diet important enough to deserve this attention from us all? And frankly, why should diet quality be a vital sign? What's the rationale for all of that? Next slide, please. My career, as Craig just described, it began in earnest really in 1993. I completed sequential residencies in internal medicine and then preventive medicine, public health. So in 1993, a little over 30 years ago, I was a newly minted preventive medicine specialist focused on leveraging the power of lifestyle and in particular nutrition to add years to lives, add life to years, prevent disease, promote health. And among the other activities I anticipated, I was going to take care of patients. I was already doing that. I wanted to run a clinical research lab, and I thought I would do what researchers do boldly go where no one's gone before, ask the unasked question, probe the unknown. And then this paper came out in the Journal of the American Medical Association. And you see the date here, 1993. This was actually just within a couple of months of my graduation. And the title, I hope you find fairly provocative. I actually think this one of the most important publications in the modern biomedical canon, actual causes of death in the United States. The basic premise here from McGinnis and Faggy was what gets listed on death certificates, often by sleepy medical residents on call in hospitals in the middle of the night, is just the most proximal information. So if someone dies of heart disease, we list the cause of death as, I don't want the slide advancing, please. We list the cause of death as cardiogenic shock secondary to atherosclerotic heart disease. And we don't go further than that. And McGinnis and Faggy said that someone who died of heart disease had heart disease doesn't really tell us much of anything. What we really want to know is what caused that. So in this paper, they enumerated 10 root causes of premature death in the United States, the things that cause the diseases that cause the death. And their list of 10 explained almost all of the premature deaths in the country every year, but for a rounding error. What captured my imagination, and now you can do those animations, Morgan, thank you, is that the first 3 entries on the list of 10, tobacco, poor diet, and this actually looks pretty good here, and lack of physical activity accounted for 80% of premature death and chronic disease. In other words, bad use of feet, forks, and fingers. So if we fix just those 3 things, 80% of chronic disease and premature death would go away. Morgan, I guess we didn't work out the choreography for animations here. 10 years later, thank you, these same issues were analyzed again, same basic conclusion. The gap between bad use of feet and forks as number 2 and tobacco as number 1 had narrowed because we were smoking less, but our diets were still deteriorating. Our physical activity levels were still degenerating. So 80% of the chronic disease risk in this country is attributable to bad use of feet, forks, and fingers, 80% of premature death. Next slide now, please, Morgan. And if we fast forward from those 30 some odd years ago to now, partly because we're smoking less, that's a good thing, but also partly because there's so much junk where food ought to be, diet quality measured objectively is the single leading predictor variable for premature death from all causes in the United States today, full stop. And that's what this op-ed in the New York Times said. Over 500,000 people die prematurely from poor quality diet, not hunger, not lack of food, but junk where food ought to be. 500,000 premature deaths and more every year. Now, if you remember during COVID, we had a national moment of reflection and mourning when we crossed that terrible threshold of 500,000 dead. But more than 500,000 people die because of poor quality diets in this country every year. Next slide, please, Morgan. And speaking of COVID, estimates are that 60% of the toll of COVID in the United States, hospitalization, ventilation, death, were actually attributable to the prior pandemic of cardiometabolic disease, heart disease, type 2 diabetes, metabolic syndrome, obesity, that in turn are much related to poor quality diet. So in other words, had we fixed diet in America and fixed cardiometabolic health going into the COVID pandemic, even without specific protection, even without vaccines, even without masking, even without social distancing, 60% reduction in the mortality toll. And if we had combined that with effective specific protection, we could have done even better still. That's a pretty impressive statistic. So it was really the prior pandemic that set us up to do so poorly in the acute infectious disease pandemic. Next slide, please, Morgan. And again, this is really all just about the importance of food for health outcomes. If you look on the other side of the same coin, okay, I've told you how bad poor diet is for health outcomes and for public health. How good can it be? This study, in brief, looked at 23,000 people in and around Potsdam, Germany, and asked them 4 questions. Do you smoke? Yes or no? Do you eat well? Yes or no? Simplistically defined as habitual intake of fruits, vegetables, and whole grains. Are you physically active on a regular basis? Yes or no? And do you have a healthy weight? Yes or no? As a byproduct of eating well and being physically active. They compared the two ends of the spectrum. So they compared, I don't smoke, I eat well, I'm active, my weight's fine too. I smoke, don't eat so well, not physically active, my weight's not so great. Over a multi-year span, these people had an 80% lesser incidence of all major chronic disease than these people. If you flip the switch from bad to good for any one of these factors, the probability of any major chronic disease over, as best we can tell, the span of a lifetime goes down by as much as 50%. But fire on all four cylinders, 80% reduction in the risk of all major chronic disease. And I'm showing 121 people listening in. Ask yourself, do you love someone who's been affected by heart disease, cancer, stroke, diabetes, dementia? And I bet 121 heads are nodding, because all our families have been invaded by these chronic diseases, largely preventable by means of lifestyle and food as medicine. And now imagine a world where 8 out of 10 of us didn't nod our heads because nobody we loved had been laid low by heart disease, cancer, stroke, diabetes, dementia, because 80% of that is gone from the world around us. That's what food as medicine can help achieve. Next slide, please, Morgan. And the power of food and lifestyle as medicine reverberates to within the double helix of DNA. Click again, please, Morgan. This study looked at 30 men with early stage prostate cancer. And rather than just watching and waiting to see if the prostate cancer progressed, these men were given the benefit of lifestyle as medicine: optimal plant predominant nutrition, routine physical activity, avoidance of toxins like tobacco, and in addition to that, good quality sleep, stress mitigation, and good social interaction. Feet, forks, fingers, sleep, stress, and love. And over a span of months, the researchers looked not so much at the men and not so much at the cancer in the men, but preferentially at the genes in the men with the cancer. And they found the lifestyle intervention took 500 cancer promoter genes and turned them off, and 50 cancer suppressor genes and turned them on. Click again, please, Morgan. Left is before, right is after, red is off, green is on. These are genes being activated by the power of lifestyle change. And you can click again just to show that this is not just one study. Click again, please, but it's a whole branch of the literature. Next slide, please, Morgan. And finally, lifestyle and diet have the power to reshape the very architecture of chromosomes. Those green tips are telomeres. They're kind of like the plastic caps at the end of shoelaces. They prevent our chromosomes from unraveling. They protect them. The longer your telomeres are, the longer healthy lifespan, other things being equal. And click again, please, Morgan. In research associated with the Nobel Prize in Medicine to Elizabeth Blackburn at the University of California, San Francisco, it's been shown that diet and lifestyle interventions can actually lengthen our telomeres. Next slide, please. It would be hard to overstate the power of food and lifestyle as medicine. We also have the diabetes prevention program showing lifestyle can prevent diabetes. The DASH studies, dietary approaches to stop hypertension, showing diet can be as powerful as pharmacotherapy for the reduction of hypertension. The portfolio diet, food can be as effective as statin drugs for lowering LDL cholesterol. Click again, please. Heart disease reversal studies, click again, please. And so on and so forth. Next slide, please, Morgan. As goes diet, so goes cardiovascular disease risk. Click again, please. As goes diet, so goes all-cause mortality. Next slide. And as goes diet, so goes healthy aging. Click again, please, Morgan. And I think the evidence that matters most is what happens to whole populations of real people in the real world over lifetimes and generations. And we have that evidence courtesy of the blue zones, places around the world where people most routinely live to be 100. The 5 blue zones span the globe. But if we were to plot their diets on a spectrum, click again, please, Morgan, from animal food predominant and ultra-processed food predominant in red on the left to plant food predominant, real food predominant in green on the right, the blue zones cluster all the way to the right. Click again, please, Morgan. Next slide. And the same dietary liabilities that are damaging our health are damaging the planet. Click again, please. We have this courtesy of many studies, but in particular, I like the work of this group at Oxford University in England, and we can look at multiple health and environmental impacts of foods. Next slide, please, Morgan. So here in chart A, we've got human health outcomes, mortality, coronary disease, colorectal cancer, diabetes, stroke. Along the side, we've got foods, and then we've got effects. Green is good, red is bad, other colors intermediate. You can just scan that quickly. And then note that B is planetary health effects: acidification, eutrophication, which is nitrogen use, mostly in fertilizer, greenhouse gas emissions, land use, water use, and the same foods along the side in the same color scheme. Green is good, red is bad, other colors intermediate. This is a bit of an eye chart. So next slide, please, Morgan. We can summarize it here. The lower left corner is where you've got the lowest relative risk of mortality for humans and the least impact on the planet. That's the good place to be. Everything in green clusters there. And it's the usual suspects: vegetables, fruits, whole grains, beans, lentils, nuts, and seeds. And in the upper right corner, we've got beef, which is harmful to both people and planet, and in particular, processed red meat. Click again, please, Morgan. So we know what the optimal diet is. It was summarized in 7 words by Michael Pollan: food, real food, not too much, mostly plants. And actually, if you eat real food, mostly plants, then not too much takes care of itself. Next slide, please, Morgan. So this has been a theme of my career, focusing on the summative evidence supporting the fundamentals of feeding Homo sapiens well. We are not clueless about the basic care and feeding of Homo sapiens. We know what food should be the medicine. It's just a matter of programs like the one just described to help us get there from here. Next slide, please. And you can't manage what you don't measure. And so this stage of my career is focused on making diet quality a vital sign. I got it, Craig. Wrapping up. Next slide, please. So I've been working on a platform called Diet ID. We've invented a way to do comprehensive dietary intake assessment over any digital interface in 60 seconds. And Diet ID is to diet as a blood pressure cuff is to blood pressure. You can learn more about this at dietid.com. Next slide, please, Morgan. And I would argue that if diet were a vital sign, if everybody knew their diet quality, an objective measure of their diet quality, the way people know their blood pressure, as a cue to action to patient and every health professional alike, we could address this systematically, universally. We would have more support for programs that make food medicine. We could add years to life. We could add life to years. Click again, please, Morgan. And we could help preserve this beautiful planet of ours. Thank you very much, everybody.
Okay, thank you, David. Our next speaker then is Paula Martin. Paula is a registered dietitian nutritionist at Groundwork Center for Resilient Communities. Her work includes culinary medicine and hands-on cooking interventions to prevent and treat health conditions and diseases related to lifestyle. She is project lead for the Esperance Community Teaching Kitchen at Common Grounds Cooperative in Traverse City, Michigan. In addition, Paula provides nutrition services with her counseling practice, Health Served Well, LLC. Prior to 2016, she provided nutrition and health promotion services as the director of health promotion programs for Carnegie Mellon University, Pittsburgh, Pennsylvania. Welcome, Paula. I look forward to your presentation.
Thank you so much. And thank you so much for inviting me. My name is Paula Martin. I'm the Community Nutrition Specialist for the Groundwork Center for Resilient Communities. We are based in Traverse City and Petoskey, Michigan. So we are a rural character town, but we do work across the state, and I'll talk a little bit more about that. Groundwork is a nonprofit that strives to create sustainable solutions around local food, climate, and clean energy in livable towns. And all these pretty icons represent many of our program areas, and that includes statewide and hyper-focused regionally. Next slide, please. Our food and farming program is celebrating 25 years. Our organization turned 30 just this last our last environmental day, Earth Day, and I also am celebrating 30 years as a registered dietitian nutritionist. We understand that local food and farming systems help keep money locally. It promotes health significantly, and I'm going to talk about my key marquee program, Culinary Medicine. And we preserve farmland, and we really do want to preserve farmland. We learned through COVID that our local food and farming system was able to feed our community. And as Dr. Katz shared, our diet quality actually was really well supported around food access. So we support farmers by finding markets for them and getting locally grown food into our food access and emergency programs. We make sure it's equitably distributed across our lower Michigan area. Farm to School is our largest program. It started when a local farmer bit into a local potato, raw local potato, and blew the minds off of our little elementary school students. And we've been going strong for 25 years and have been changing our school systems by embedding farm to school professionals in those systems. And Farms, Food, and Health is my baby, my project area. And we can go on to the next slide. So here we are in Michigan. I spend most of my time around the 18 on the map. In February 2022, one of the headlines in our region said that we're in an Alice Wonderland, and Alice stands for Asset Limited Income Constrained Employed Households. So an Alice Wonderland on how we are in a paradise status in northern Michigan, but this paradise status does hide staggering levels of poverty. And also, believe it or not, close to 70% of our adults in our 18 area are not meeting daily fruit and vegetable requirements. So while we consider ourselves a resort town, we all have a lot of work to do in that area. This year, we have expanded our Building Resilient Communities project. This is a statewide project that is a policy systems and environmental program. So we provide small stipends to anybody feeding folks in the community to provide local food, and the stipends can be used for a host of things to help the local food get into the mouths of our community members. So it can be processing equipment, it could be help for transportation, it could be education that's needed for our for the folks that are either volunteering or paid in emergency food systems, healthcare systems, school systems, senior feeding programs across the entire state. Next slide, please. So in our Farms, Food, and Health program, our goal is to keep very close to the farm and the farmer. This picture is us bringing a host of healthcare providers to our local farmers market. They met with the farmers who are growing the food there. And they are also having really deep, in-depth conversations with culinarians and chef instructors. Culinary medicine blends the art of food and cooking with the science of medicine. And we wrap in nutrition science, and we wrap in practices around behavior change. And then, of course, local food get into the highest needs of our community. Overall, our Farms, Food, and Health program has some unique curriculum goals. So there are culinary medicine training programs across the United States. We modeled our culinary medicine program after the Healthy Kitchens, Healthy Lives, T.H. Chan School of Public Health and American Culinary Schools program. The gentleman in the corner in the blue shirt is Dr. David Eisenberg. He came to our first culinary medicine conference to share all the research and promote teaching kitchens, of which I will talk about as well. So we are learning from farmers, and we want farmers to educate our healthcare providers. So we have farm market managers that provide continuing medical education sessions. We have folks that are in production, like farmers. We do farmer field trips. We go to the land where the food is being grown. And then we also think about farmers as our patients. So, we have a beautiful amount of farm and growing produce in the region, but farmers are also experiencing a lot of stress, and it's a hard work to be a farmer. So we do take quite care to think about farmers as our patients. We think about prep and consumption of the food, and we also look at waste recovery. In our culinary medicine programs, we started our first Farms, Food, and Health collective gathering. So we brought together teachers, administrators, healthcare system administrators, regular people in the community, emergency food providers, and they all sat together in a room. We bring in content experts. In 2016, we launched our first prescriptions for produce program in the region, and culinary medicine started in 2017. You can forward. So we really ensconce our healthcare professionals when they come to our culinary medicine conference in the local bounty. So we intentionally host our conferences in late September when our bounty is at the highest. We go to the farmers market and we set up these beautiful grazing tables. I don't know if you've been to a medical conference, but the food is not something that people usually rave about. But we have these beautiful bounty, and the food is the center of our culinary medicine conferences. And what is so interesting about our conference is that we've had not one, but three national speakers come and all remark about the diversity of the speakers providing culinary medicine training. And then we spent a lot of time really being on the land, on the farms, and bringing the farms to the conference. Next slide, please. So if you're interested in how we got our culinary medicine program started, we published an overview with support from the Michigan Health Endowment Fund and our local Rotary charities. It was called Culinary Medicine, Cooking Up Some Continuing Professional Development and Bringing a Community Together in Traverse City. You can hit that QR code and it'll take you right to that article. So my first important aspect is to share with you that food as medicine approaches can achieve nutrition security and improve health. So you saw that lovely pyramid, and we work very much so around that population level. So we want to train all of our healthcare providers. The vast majority of healthcare in our rural region does take place in the outpatient setting. And we have been targeting pediatricians and family practice physicians in our culinary medicine work. We also have been working closely with the state of Michigan. They just will be launching in June part of their Medicaid health plans in lieu of medical services. And that does cover prescriptions for produce programs, medically tailored meal programs, medically tailored groceries, and then healthy food boxes. So we are working through our Medicaid program to get this across the whole entire state. Go ahead, next slide. So we understand that embedding culinary medicine, while we had these beautiful conferences around every 18 months, there's no way we're going to be able to reach all of our healthcare providers who need significant education. So everything that Dr. Katz shared with us, the research, the bedrock of this work, we need our healthcare providers to understand that just as well as registered dietitians, nutritionists do, lifestyle medicine practitioners do. So we opened our teaching kitchen, the Esperance Community Teaching Kitchen, in 2023. And we are embedding our culinary medicine training every quarter now. So instead of having one larger culinary medicine conference about every 18 months, we are doing it quarterly now. So you can see the smile on my face in this picture, because the number one feedback I hear from healthcare providers, we are tracking how they're using this information. We are tracking who they're sharing this information with, but they give me joy back. So I don't know if you remember, but we had a pandemic and our healthcare providers really just became worn out. So this is a place for joy and renewal and growth for our healthcare community. So we need to support and help our healthcare community so they can then go out and help their patients. And again, our farmers are our patients as well. So it's big fun. We get serious work. We've studied diets through the life cycle in our culinary medicine classes. We've done disease-specific focus training on cardiovascular health, diabetes, and overweight and obesity. We have also looked at the Eat Lancet report on our climate and our health. So we've done CME related to that. And we also really want to help our providers increase their own patient rapport. So, how we communicate with our providers, how our patients and our providers are communicating makes a world of difference. So we do a lot of motivational interviewing training, and it's really the best food ever. We can go to the next slide. So what's really important is that we follow our community health needs assessment when we're developing our culinary medicine programs. This is a picture that warms my heart. We have a medical resident with the great knife skills working alongside a dietetic intern. So we're working with medical residents and students as a target population, and they are medical residents through the Munson Family Practice program. So we build off our common goals and our community health needs assessments, and we also try to find a bunch of allies and champions. So we could not do this work without our champions at our Ag Grant, Michigan State University, and Munson Healthcare. Go ahead to our next slide. So we're just going to go through a couple of these. This gentleman is a lifestyle medicine physician. He's new. He's in one of our regions that has 11% food insecurity, nutrition insecurity. We brought in food from our local food pantry. He is preparing a canned a salsa made out of peaches and a lovely food that we source from our food pantry. And then we also get to have fun with food. So this is a beautiful mushroom, yellow oyster. One of our chef instructors, the director of the culinary school. Our team is filled with high-skilled professionals that really understand our region and our community. So cross-disciplinary teams are the best. And I highly encourage you, if you're starting to think about culinary medicine, that you need a registered dietitian on your team and a chef educator. Without that, you probably aren't going to get too far. So I could talk about our food and farming work for hours, but thank goodness we wrote a book called Shared Abundance, and it is a playbook on lessons on building local food. Our food farms and health program is at the end of the book because we really need to build a local food economy in our region so we can get more of that nutrient dense, delicious food on our plates. That's it. Thank you very much.
Okay, thank you, Paula. I appreciate that excellent presentation. Our final speaker for today is Devin Clattel. She is the Vice President of the Food Initiative at the Rockefeller Foundation. Devin oversees the foundation's global food strategy, working to advance a more nourishing, regenerative, and equitable domestic food system. She works with schools, hospitals, policymakers, and others to help more and underserved communities access and eat healthy, sustainably grown food. She also leads their work on the true cost of food, which analyzes the hidden costs of the food system on health equity and the environment. Devin holds a BA from Harvard University in cognitive psychology and an MA in food systems from New York University. Please join me in welcoming Devin.
Thank you so much, Craig, and thanks to the Farm Foundation for having me. I can see the questions coming in, so I'll try to go through my presentation quickly, and luckily the benefit of being last is that I can build on all the great points made by the previous speakers. So as Craig mentioned, I'm a part of the food team at the Rockefeller Foundation. We are a private philanthropy. We work globally, and we have been working in the area of food, nutrition, agriculture for over 100 years. Next slide, please. And in the past 5 years or so, we've been particularly focused on increasing access to healthy food here in the United States. As Dr. Katz did an excellent job of laying out in his presentation, we now know that poor diets are the #1 cause of poor health and death and disability around the world, including here in the US. And so I won't repeat the stats that Dr. Katz mentioned earlier, but I will just mention that one thing that is particularly top of mind for us at the foundation is that the burden of poor diet is not shared equally amongst different communities here in the United States. We know that certain communities suffer disproportionately from the health effects of poor diet, and those include rural communities, seniors, veterans, communities of color, and low-income households. And so those are many of the communities that we focus our work on. Next slide, please. One thing that you might have heard in the previous comments, but not only is diet a driver of poor health in this country, but it's also a tremendous driver of healthcare costs. The United States spends more money on healthcare each year than any other large wealthy country, and yet we have the worst health outcomes per capita. So it turns out that we're quite good at paying for healthcare, but not particularly good at buying health, at buying positive health outcomes. And Craig mentioned our work on the true cost of food. So the Rockefeller Foundation put out a report in 2021 on the true cost of food. And one of the key findings was that we actually spend over $1 trillion each year on human health related costs that originate from what we eat, originate from our food system. So we spend about $1 trillion on food in this country every year, and then we spend about $1 trillion on the poor health impacts of that food that we've eaten. So not only is this a tremendous sort of cost in terms of health outcomes in the country, but it's a real economic burden. And I think as we're starting to see in the current dialogue and in the current context in this country, this is starting to get the attention not just of doctors and patients, but also of policymakers, of health insurance companies, and many of the partners that we work with in our food is medicine work. And yet, like, our healthcare system doesn't really have any tools to offer patients that are suffering from a diet-related condition and aren't able to access healthy food, either because they can't afford it, or they might not be able to get transportation to go buy the food from the grocery store, or they might not have fresh local food close to them. Next slide, please. At the same time, we have this immense poor health problem, this immense economic burden, and we were starting to see really innovative programs all around the country, like the program in Oklahoma that Erin is running and many others, who were offering fresh food to patients with diet-related conditions and getting really positive outcomes. So getting health improvements, which Erin and others have spoken to, things like increase in fruit and vegetable consumption, decrease in conditions like obesity and blood pressure and diabetes markers, which you see here listed as HbA1c. And also bringing down healthcare costs. These patients are often getting off medications, as previous speakers has mentioned. They often need fewer intensive interventions, fewer emergency room visits, and that has a really positive return in terms of cost effectiveness. Next slide, please. And so back in 2019, the Rockefeller Foundation began to support different aspects of this growing food as medicine space to see if we could start to scale it from effective local programs to more of a national program and policy that's available to all Americans who need it. We've committed $100 million in the 4 sort of broad areas that you see here. So we fund quite a bit of research in the food as medicine space, trying to understand which programs work best for which types of patients, how to optimize their design. And in that endeavor, we are partnering with a number of key partners. One is the American Heart Association, where we've set up an initiative called Healthcare by Food, which is focusing on food as medicine trials, research trials. Another is a partnership we have with the Veterans Health Administration, where we're working with veterans in 5 different states to offer them food as medicine programs and try to improve their health. So we do a lot of work on research. We do a lot of work around policy, which I'm sure we'll talk about in the discussion, but trying to educate policymakers around the potential and promise of these programs, not just for healthcare providers and patients, but also for communities, local economic development, and farmers, which I'll talk a little bit more about. We support better infrastructure. So we support operators that are running these programs and helping to link them to their communities. And then lastly, we do some work around communications and messaging and trying to educate the broader public on these programs in different parts of the country. Next slide, please. So one of the points I wanted to lift up, particularly given the Farm Foundation and the focus that you all have, is that as the food as medicine market grows, we think that it could unlock a really robust market for local food and healthy food in the US. We think that if food as medicine programs are able to be fully reimbursable, as Erin mentioned has happened in Oklahoma, all across the country, that could unlock billions in revenue for small and mid-sized farmers. And as we build this food as medicine market, and as we try to recruit the healthcare system to be a partner with us in helping to improve dietary quality, if we do that well, we'll be able to build a market that not just supports patient health and improved healthcare options and improved outcomes for healthcare providers, but also supports the kind of food system that we want to see, a food system that prioritizes small and medium farmers, that prioritizes and promotes local food, fresh, unprocessed foods, helps to support farmers that are prioritizing human and planetary health in the way that they're raising and distributing that food. And so next slide, please. One of the exciting sort of sets of projects that we have supported this year is supporting a number of innovators in different parts of the country. You can see some examples of those groups here, who are really focusing on sourcing from local farmers across 9 different states and Washington, D.C. area, and trying to both support those models and show that they can work at scale, but also support evaluations to understand the economic impact of those programs on small and medium-sized farms, and then use that research to inform policies so that future food as medicine programs can start to integrate more program design elements around local farming. So just to speak to maybe a couple of examples that you can see here, we are proud to support a group out of Massachusetts called Community Servings. Community Servings provides what's called a medically tailored meal. So that's essentially a fully prepared meal that gets delivered to patients and is optimized for the diet-related condition that that patient has. They're serving about 7,000 families per year in Massachusetts and Rhode Island, and have been experimenting with forward commitment to farmers to be able to give community servings, predictability, while also helping farmers to plan their crops and be able to grow their local farms and local sourcing agreements. 4P is another fantastic example of a group that is connecting food as medicine programs with more than 200 small and mid-sized farmers throughout the Mid-Atlantic and providing produce boxes that are 100% regionally sourced year-round. So as we're growing the food as medicine interventions from a policy perspective and the market, we are trying to keep an eye on, again, how we can use the buying power of food as medicine programs as they grow to support farmers and the kinds of food system that we'd like to see. And one of the exciting areas of movement in this space, which I'm sure Erin can speak to also, is starting to see policies at the state level in those state level programs that Erin mentioned, which are preferencing local food and local food as medicine implementers. Next slide, please. And then lastly, before I sort of wrap on the food as medicine work that we've been doing, I just wanted to mention another initiative that we host at the foundation called the Periodic Table of Food Initiative. And this is a long-term bet that the foundation has made to really more deeply try to understand the nutrition quality of our food and the makeup of our food in a way that goes far beyond the sort of 12 vitamins and minerals you traditionally see on the back of a food label at the grocery store. As folks on this call might know, right now we really don't understand what's in a lot of our food at a molecular level. We understand about 1% of the makeup of our food, and there's not really standardization globally around how we measure and report on the composition of food. And because of that, it's also really challenging to understand how that composition and nutritional quality varies with different production methods. So part of the goal of the Periodic Table of Food Initiative is to create a new global standard for how we measure the nutritional quality of food and really expand our understanding, including differences we might see in micronutrients between a plum grown in California from a plum grown with regenerative practices in, say, Chile. So I encourage folks, if that's of interest of you, to go to the Periodic Table of Food Initiative website. You can actually play around a little bit and understand better the different molecular makeup of some of the foods that we've analyzed to date. And next slide, please. And I just want to end by saying, I think what's really encouraging about this moment, and I think what we've heard from a lot of the panelists today, is I think we've come a really long way in terms of elevating the scope and scale of the problem when it comes to dietary quality. I'm participating in more and more of these kinds of conversations where people are lifting up just how dire the crisis is around diet quality and what it is costing us in terms of health and in terms of healthcare dollars and in terms of health disparities. And I think that's encouraging a lot of ways. I think we have a lot of agreement on the problem. And what we'd like to see now at the foundation is really focus on practical, accessible, and effective programs and solutions like food as medicine interventions that support healthy patients, healthy food, and healthy farms. And as we think ahead to scaling those programs, we have a lot of optimism and hope for our ability to start to tackle this problem. So thank you, and I look forward to the discussion.
Okay, great. Thank you. Thank you, Devin. I'm going to, as in my prerogative as the moderator, I'm going to ask actually 2 questions at the outset. The first question I have is, I mean, there's a lot of talk about local foods. Local foods are great. Who doesn't love that farmer down the road growing something and all these wonderful things? No doubt about it. But if you look at one of the successes of agriculture that I was talking about at the outset of this thing is that we have a global agricultural system. And having locally grown food is kind of pushing us back to the 1800s when you didn't really have the scope of this. And if we want to have fresh fruits and vegetables year round in, say, North Dakota, there's not going to be a lot of options for growing that in North Dakota nearby. Or, I mean, there's not enough scope for local agriculture in a lot of our major metropolitan areas. So one of the beauties of commercial agriculture is producing large-scale apples in Washington, tons of fresh fruits and vegetables in the Central Valley of California, fresh meat from our great ranchers here in Texas, dairy farmers up in Wisconsin, all across the country, but moreover, globally. I mean, if we think about many imports from other countries, enables us fresh fruits and vegetables. Now, again, I just want to pose a question. Local foods are great, but they really are a tiny, tiny, tiny proportion of the amount of food that's available. And even if it was expanded, we just don't have the scope to expand it to it's a larger thing. So I want to figure out like where you see local foods being a part of this, despite the fact that they'll only be a tiny proportion of the overall production in the United States. I should also note is the Farm Foundation. I mean, there's a lot of the people involved in Farm Foundations run these large commercial agricultural farms. So a lot of Farm Foundation has been involved in this for a long time.
I could start if that's
Okay.
So we use a both and approach at the Groundworks. And it's important to understand that a program like Double Up Food Box, for example, we are using Double Up Food Box as our nutrition incentive program at our farmers market, but they are also available in grocery stores, right?
Okay.
And many of our food programs do use federal commodity programs. So For Dipper is an example of that, and other child food programs that are specifically called out in the Farm Bill. So Groundwork understands Michigan is the third most agriculturally diverse state. We do have storage crops all year. We use a lot of high tunnels and hoop houses. So we do have a pretty robust selection year round of local food, including dairy and meats. So we use a both and approach because we understand that, we are trying to improve nutrition and diet quality. We aren't trying to be, we're pretty agnostic when it comes to the type of farming systems. Now, we do encourage people to understand soil quality and work to preserve soil quality. One, for, algae blooms in the Great Lakes and our fresh water supply, but also for improving nutrient density and quality.
Hey, Craig, just a couple of comments. Obviously, I can't speak specifically to farming practices, but from the public health perspective, a lot of initiatives are focused on, if you will, decentralization of control over the food supply in ways that also engage community and address public health threats. So urban gardens, for example. And of course, we have modern innovations like hydroponics and solar-powered greenhouses that also allow for more local production at relatively low energy cost. But I completely agree, Paula, with the both and. I think there's opportunity to more widely disseminate the ability to contribute to the food supply. We're all participating in the food demand. More people certainly can participate in food supply. There's great work by organizations like Food Tank, run by Danielle Nierenberg, about empowering people to have some control over their own food production. So more and more people can be farmers of a sort. And yet, you're quite right. There are not only is there an advantage in terms of the diversity of food consumed if you source it from all around the world, so you're basically following the sun and not subject to the limitations of winter, for example. But in addition to that, there's significant variation in the efficiency of production in different parts of the country. I work closely with two leading experts in the environmental impacts of foods, Guy Donachel at Barnard and Marty Heller, formerly of the University of Michigan. And actually, we appended to our work at Diet ID something called DIEM, dietary impacts on environmental measures where we scored the environmental footprints of different diets. And one of the things we looked at was water use relative to water scarcity. And so, for example, the environmental impact of growing tomatoes and the water they require, or almonds and the water they require in a place where water is abundant, it's a much lesser footprint than if you grow in a place where water is very scarce and you essentially have to pull from one need to satisfy another. So I think the answer that Paula provided is right, both and. There's opportunity for a lot of local production, but I think you're also quite right, making a good point. If we want to enjoy this diversity of food year round, we have to source it globally.
Yeah. Okay, Devin, did you want to respond, or did David and Paula make the points you wanted to make?
Yeah, I mean, I think they basically made the points. We support food as medicine programs that operate at national grocery retailers, right? And those are sourcing from all over the world. I do think it's important to recognize that local sourcing can have additional benefits beyond additional benefits in terms of local community benefits, education benefits, economic development benefits, right? Helping to support farmers that might go into what in this country we call specialty crops, but is really fruits and vegetables that go beyond some of the very large scale commercial farms that might not be producing the same variety. So I think there are benefits to the both and model. And so agree with Paula and David on that.
Okay. Sounds good. I'll give you plenty of time to respond, Aaron, to other things, but let me move on to just my one more question. At the outset, I said, one of the things about the Trump administration is they're doing a lot with respect to, promoting a lot of the things that the four of you are talking about. And one area in particular the Trump administration has been moving forward, especially with Republican legislatures, is to put restrictions on what people can consume with their SNAP benefits. As many of you know, SNAP is the leading program against food insecurity in the United States. It's demonstrated again that it's a successful program, and it's a large program, provides assistance to about 50 million Americans. But there's been some who currently with SNAP is you can purchase whatever types of food, no food, drugs or no alcohol or tobacco. And there's some restrictions. For example, you can't purchase rotisserie chicken. But there are some who have been proposing, especially there's several Republican red states, including my own Texas and then Arkansas, a lot of proposals to restrict what people can purchase with SNAP. And these vary from everything from making it basically you can't purchase meat or you can't purchase processed products. I mean, basically making SNAP like WIC in terms of not being able to purchase many foods, all the way down to more narrow things like banning quote unquote candy or quote unquote sugar sweetened beverages. And this has been one of the major initiatives by the Trump administration, began under the Biden administration. Now, for a lot of anti-hunger advocates and those who are concerned about the well-being of vulnerable Americans, this raises a lot of concerns due to the stigmatization of SNAP, due to what we see in other programs when you impose all these restrictions and things like this. So I wanted to get a sense about, whether this is something that intersects with this quote, this food as medicine, is insofar as a lot of people would say, well, that this is consistent, these SNAP restrictions are considered as food as medicine. So I want to get your thoughts on that, on those restrictions.
I'm happy to weigh in. I just dropped in the chat for everyone a paper we did some years back in Mayo Clinic Proceedings. We did a study where we actually compared the objectively measured diet quality of SNAP participants and demographically matched non-participants. In other words, SNAP eligible people who had all the same socioeconomic characteristics but did not participate. And diet quality was actually lower among the SNAP participants. And so that's, if we want to look at the liability of saying you can spend your SNAP dollars on anything, you can buy more junk food, you can buy sugar sweetened beverages, we're going to basically subsidize access to more junk food. One of the intrinsic problems is that a very potent driver of taste preference is familiarity. Taste buds are adaptable little fellas. When they can't be with foods they used to love, they learn to love the foods they're with. If they're with junk all the time, they learn to prefer junk, highly processed food, excess sugar, excess sodium. And then when you have more money to spend on food and that's what you're used to and that's what you can access and that's what you like, you tend to buy more of that. So if the point of SNAP is just to enable people to buy whatever they want to put in their mouths, you'd say, avoid the nanny state imposition of telling people what they could buy. If the point of SNAP is to help people get a higher quality diet, I think it makes perfect sense to put boundaries on that to ensure that this is actually nourishment. It's not just ingestible stuff, but it's actually nourishment. And I think we could be innovative in this space where we actually provide guidance to SNAP participants about quality in every aisle of the supermarket, all the different choices they have, and ideally link the purchasing power of SNAP vouchers to the quality of foods so that we help people who need this assistance choose good food to get to better health. And by the way, this was characterized by Devin, where we spend a fortune on food overall, and then we spend a fortune on treating the chronic disease that results from eating bad food. Basically taxpayers are subsidizing SNAP to lend assistance to people to buy poor food to get to poor health. And then the same taxpayers are subsidizing CMS to pay for the cost of that. So I think there's an argument to focus on using SNAP to elevate health by elevating overall diet quality.
Okay. Aaron, let me turn to you, please.
Thank you. Yeah, I would agree. I think it's a very controversial topic because there's lots of people that think if we change SNAP that it's like a trickle down effect and we'll just cut the whole thing or something. And I think that's kind of a fallacious type of thinking. I think we do need to realign it, but it's kind of a both and kind of situation where, yes, we need to probably change how those things are being spent, but we also have to teach people, particularly people who are low income, who are time constrained, who just don't have the knowledge or the awareness, really empowering them to stretch produce particularly. And that's why FreshRx, we did choose not to take SNAP because we use it as a teaching tool to say, hey, you don't have to put your limited SNAP dollars on the line to try this eggplant, but we're going to give one to you and we're going to teach you that actually you like it. And then we're going to show you where to use your SNAP and your double up, where you can even use it on these regenerative local growers, which is really cool. So I think you can change SNAP, and I think we ought to in a lot of ways, but we have to support people. And I do think that there's a lot of conversations about using these dollars for these types of food as medicine programs that people could maybe opt into them. And we also have to fix issues where like people move into housing and they use their housing, like their reduction in housing costs against their SNAP dollars. It makes no sense that you move into housing and you go from having $300 a month of SNAP to $30. So people can't make these more educated choices at the grocery store. And so we have to support them on both sides.
Okay, sounds good. Okay, I've written a lot on this, so I take a different position on this. And I'm not going to share another thing, but I've written quite a bit on this for those who are interested in why I think SNAP restrictions do grave damage to the dignity and autonomy of low-income Americans. So I just want to go on the record with that. But one of the other things is that we also have one prerogative, along with giving the conference, the moderator, the ability to ask a couple of questions. We also give the president and CEO of Farm Foundation the ability to ask the next set of questions. So let me turn it over to you now, Sherry.
Thank you so much, Craig. Are you able to hear me all right? Great. So as Craig mentioned, first, thank you, Craig, and to our panelists for this wonderful contribution. I think there's going to be a great further discussion, and thank you for the opportunity for me to jump in. As Craig mentioned, I'm CEO of Farm Foundation, and I am here live at our Innovation and Education Farm Campus in Libertyville, Illinois, where we have a wonderful audience outside, and they are submitting questions. I'm going to ask one of their questions in a second. The other opportunity they have today is to go onto our farm campus and pick asparagus live while it's at its peak nutritional value straight from the farm field. So great topic today for our local audience here as well. So they did have, this audience had lots of questions around SNAP. So thank you, Craig, for posing that question. I think we could follow up with more discussion there. But I think what I will do is there were some questions from the audience about different age groups and how the panelists think about that. So for example, for children and teens, how can either your programs or other ideas for encouraging healthy eating habits early on in life so that it can be sustained throughout life? But then at the other end of the spectrum, for older citizens of the United States, is it ever too late? Or can people still dig in and have an effect on their health outcomes? So thank you for the opportunity for that question from our wonderful audience here.
I'll jump in as a gerontologist that says if you think people are too old to change, it's ageist. It's never too late to change, and most people in our program in particular are over 55. We've had people all the way up to 90 years old, and we've seen people in their 60s and 70s reverse their chronic disease. So it's never too late. We do partner and do sourcing for a United Healthcare project in North Tulsa with kids. And so there's two organizations that run that education. They show the kids how to grow their own food. They understand how to cook and understand nutrition. And then we supply the food for those families. But I think when you're talking about kiddos, you have to educate the family because, of course, parents are doing the purchasing. So it's got to be a full family kind of intervention.
I could go next. So, as part of our Farm to School initiative, we absolutely get kids. We think about education in the classroom, education in the cafeteria, and then education growing food and school gardens. We do family cooking nights in our rural school districts, so that gets kids and parents cooking together. One exciting intervention is teaching kitchens. So we can get our teaching kitchen is set up like a home cooking environment. We have adjustable tables, chairs. We can get all abilities and all ages in there, hands-on cooking. We work with electric induction cooktops and can move them however we need to. We partner quite a bit with our SNAP educators who are working with teen moms, are working with people with all levels of ability to learn to cook and learn how to use the food that they're seeing in the food pantry. So as we continue to increase the whole plant-based foods in our emergency food pantries, we are really working hard to make sure we're educating everybody across the spectrum. And I think I shared that we started our prescriptions for produce program in pediatric outpatient clinics, and we have moved to federally qualified health centers and also our family practice offices. So they are seeing the whole spectrum of nutrition across the life cycle.
Thank you so much. And we are
Okay.
submitting questions in the
Right.
Q&A section as well. So
Yeah.
thank you. Look forward to the discussion.
Okay, so I'm going to take these questions kind of not necessarily in order because I want to be able to give people the different things. So I'm going to frame this question from Matt Enright, and he says, what are some of the implications of the rise of food as medicine for farmers? What are the benefits and also some of the challenges? I want to put this in a little bit of context. I mean, as you know, I mean, in a lot of our states is that if you think about agriculture, I mean, it's large scale family farms. Take my former state, Illinois, or my former state of Iowa. These are big farms, predominantly growing corn and soybeans. That's, I mean, virtually all the land is utilized for those. And oftentimes there's a lot of demonization of these farmers, even though the family farms have been there in business for 150 years. But you see, none of the four of you, but you see other people demonizing these farmers. And for that matter, in the great state of Texas and in Oklahoma, a lot of our ranches are being demonized by people around the country. So in thinking about this, how do we figure out ways that we can promote food as medicine in the ways, the benefits to these farmers, with at the same time not demonizing them? Again, I know that none of the four of you have, but you do see rhetoric sometimes demonizing these farmers in the corn and bean and ranching. And so just your thoughts on how opportunities can emerge with respect to food as medicine for farmers across the United States, both small scale and large scale farmers. I mean, talk about both. And I would add one thing, how can the land grant system help in this? For those of you with land grant connections.
I think the extensions play an amazing role and could play more of a role. They're really intended to do this in the communities. They, you know, if there's not a medical institution in these rural areas, there is a county extension office.
Right.
With some a little bit of tweaks and some additions on the nutrition education. that needs to be more lifestyle focused, and also could be a central hub for aggregating that local food and distributing it. So I think it's an incredible way to be scaling these programs, and training even those extension offices as community health workers, et cetera, which they probably kind of are already. I think food as medicine is this incredible market that could finally value farmers for their quality of their food over their quantity. And no shame on large scale commodity crops, but there is more subsidies for tobacco in this country than there are for fruits and vegetables. And we hope that this will adjust and create this whole new market for large and smaller growers. And those larger growers who maybe don't use certain soil health practices, like we were just doing what we were told to do and taught. And we didn't really learn a lot of some of these impacts when we were trying to produce more calories. We didn't know. So there's no shame. We didn't know until about the 90s when more studies came out, that we ended up kind of depleting the nutrients in our food, but we can actually restore it a lot quicker than we destroyed it. So it's super exciting. There's lots of great people like Rick Clark does this on thousands and thousands of acres at a commercial level. So it's something you can do if you hook up with like No Till on the Plains, Rick Clark, John Kemp. They can help you kind of implement certain changes. And of course, a lot of people are just doing what their father taught them to do and what their neighbors are doing. And that is totally what people do and what we were taught to do and what we've been subsidized to do. And so there's no shame in that. And now we learn more and we can do different things and improve the system. So it's super exciting for everyone on this.
Okay, great. Thank you, Erin. I wanted to turn to the next question. And one of the things I think where there's agreement between David and myself on some of these things about SNAP is giving people the tools to make decisions with respect to what they choose to eat. I think that's we try to find areas of agreement. And so Donald Viacelli has this question and this may point to some of this, and I'd be interested in the four of you talking about this, is how would food labeling for nutritional values of food items help solve the health issues we face as consumers? But more broadly the current nutrition labeling, but also are there other things that you've seen that you think are particularly effective at conveying information on food labels to individuals?
I could share that. I know that
Okay.
there's been efforts on some front of label packaging. So, there are certain countries that use stoplight, red, green, yellow indicators on foods that may have higher nutritional quality or value. So, there's been several proposals on front of label packaging at the federal level. And I do think that we will see some of this in the future. In addition to the nutritional value, there are some really innovative front of label packaging that also looks at the climate or the carbon footprint of the food items as well. So that might be another area that we see some front of label packaging.
David?
Two comments. Basically, efforts that consecutively have taken up 2 decades of my career. So first, led a team of international scientists, 2 years developing something called the UNCI, the Overall Nutritional Quality Index. It saw daylight as a commercial program called NuVal. 1 to 100, the higher the number, the more nutritious the food. 30 nutrient entries, each nutrient entry weighted for the prevalence of the condition, the severity of the condition, and the strength of association between a given nutrient and a particular health outcome. And it was deployed at its peak in 2,000 supermarkets nationwide. And I was traveling the country at the time, and we published a number of papers. So you can, those of you interested in the peer-reviewed literature, just go to PubMed and type in Katz DL and ONQI, ONQI, and you'll pull up some of the papers. But we found it shifted shopping patterns. It elevated overall diet quality. When I met people around the country, I met people who lost 40 pounds, 60 pounds, 80 pounds. One gentleman in Tennessee, shopping at a supermarket that had this system, lost 180 pounds in 18 months just by trading up the quality of his choices at the supermarket. Because in every aisle of the supermarket, there's higher and lower quality. There are some, for example, marinara sauces that you pour over spaghetti that have more added sugar per calories than anything in the dessert aisle. And there are other marinara sauces on the same shelf that have no added sugar at all. Those kinds of differences people don't know anything about. And systems like this can enable them to make those better choices, one bag, one box, one jar, one can at a time. And the aggregate effect on overall diet quality can be tremendous. And then the second effort is the one I already described. So we're currently focused with Diet ID on enabling anyone who wants to know their diet quality to know it just like they know their blood pressure. Something called the Healthy Eating Index 2020. It's a 100-point scale. What is your objectively measured diet quality relative to what it ought to be? I think if we can democratize access to that information, it will work like blood pressure does. If your blood pressure isn't what it ought to be, you're going to pester your doctor and say, what should I be doing about it? It's a cue to action. And I think we should be doing that with the quality of individual foods that make up diet, as well as with the quality of overall diet, because it's too important not to measure and not to manage.
Yeah. Okay. So the next question is from Elizabeth Wilkin about prescriptions. But before turning to that, I want to talk about one prescription, which if you talk to food retailers, you talk to food manufacturers, you talk to people in the public health and nutrition communities, is what's really upending a lot of things pertaining to nutrition and health is the introduction of drugs of Ozempic, Zepbound, and some of these other products, which are really, in terms of reducing weight at least, has led to some pretty sharp declines. The studies seem to show declines in weight, declines in AIC counts in terms of diabetes, also in terms of reductions in, say, drinking and other addictions that people may have. So how do you see the introduction of these new drugs playing into all that you're working on in these spaces? What are the implications of this? Do you see people if they're eating a lot less, will they be eating more consistent with this food as medicine, or what do you all see happening with this, and how does this have implications for your work?
I think this is my ball as a physician. So you're talking about the GLP-1 drugs,
Yeah, exactly.
glucagon-like protein analogs. These are drugs that essentially function much like glucagon. Very interesting story. The whole tale of the GLP-1s, also called incretins, begin in the saliva of the Gila monster, believe it or not. You could Google that if you want to find out how we identified this compound in lizards and went on to produce blockbuster drugs that changed the economy of some whole countries. So these are extraordinarily powerful drugs with many, many beneficial effects. And I'm not a huge fan of pharmacotherapy when farms can be the therapy that we need. I prefer food as medicine to drugs as medicine, but you have to tip your hat to the power of these drugs across a wide array of conditions. But recent study in JAMA Internal Medicine indicates that these drugs are actually not cost effective. They're highly effective, but they're so expensive at current price points, they do not meet the prevailing standard in medicine for cost effective. So they're cost ineffective. Second, there are many known side effects, some of them quite serious, like pancreatitis, but nausea, vomiting, diarrhea, unpleasant things are quite common. And then the more severe side effects, less common, but not exactly rare. The other thing is these drugs mobilize lean body mass at least as much as body fat. So people lose muscle taking these drugs. And then finally, they do tend to shrink the amount of food you eat, but they do nothing to elevate diet quality, which reverberates across every health outcome for an entire lifetime. So powerful drugs, definitely useful for people who are otherwise struggling to control their weight, who might otherwise be thinking about bariatric surgeries, definitely appropriate for people with type 2 diabetes, but not a substitute for optimizing diet quality, which can be in addition to these drugs to make sure as you shrink yourself and shrink your diet, you preserve lean body mass and you preserve diet quality. These drugs can be transitions to healthy eating for a lifetime. We ought to be thinking about healthy eating for a whole household, and parents are not and should not be sharing these drugs with their kids saying, here, I'm going to use this to control my weight. You can share my prescription. But everybody in a household could benefit from higher quality nutrition. So we basically need programming that supports elevation of diet quality, preservation of lean body mass while on these drugs, and the notion that you're not going to want to take this drug for the rest of your life. If you use it for a period of time to lose weight, you need something to transition to. Clearly, that's optimizing nutrition.
Okay. Devin, did you want to speak to that as well?
No,
or you had to mute off?
I agree with all of David's points. I think the cost effectiveness one is one we've been hearing a lot about from health insurers and large employers, which is that you know, the cost of providing these GLP-1s to everyone that is eligible for them is tremendous. And I think in some ways that has sparked innovation of what else can we provide alongside these drugs to help patients transition off these drugs. You know, how can food as medicine and diet-based approaches be complementary to these drugs, which, you know, as Dr. Katz said, agree, we want all the tools available to patients who need them. And there's lots of reasons to think that food-based approaches should sit alongside pharmaceutical-based approaches when it comes to dietary health. So agree with those points. And we're seeing a lot of those conversations happening, calls of folks that are thinking about GLP-1 coverage, but wanting to know what else is out there. And I think, you know, one benefit again of this moment has been like the dialogue around these issues has just become quite loud in a good way, I think. And in some ways, I think the GLP-1 innovations have forced more medical providers to really think about nutrition and diet, which has been helpful.
Yeah. And it'll be interesting as the price of these decline, because they've already been declining sharply as they come. So I wanted to pose a question I think was probably they specifically referenced Aaron in this, but Aaron and Paula with some of your work. So this is from Deborah Mack. For the speakers who have community food programs, are you collaborating with existing programs like Meals on Wheels to reduce duplicity and have stronger programs? I've actually tried to do this, but found it difficult to source food directly from farmers. Any thoughts on that, either by Aaron or Paula?
We absolutely, in Northern Michigan and across the state, do partner. So we try really hard to not have duplicity. We have a USDA Regional Food System Partnership Grant. So that really helps us network and understand what farmers are doing, producers are doing, people in emergency food systems are doing, and school districts are doing. So we have peer learning networks, and we are all across the Western state, from Muskegon County all the way up to the Bridge in Michigan, if you're familiar with our Michigan again. So we absolutely try to do that work in conjunction, in networking, in collaboration, and through partnership. And one of our major funders, the Michigan Health Endowment Fund, does an excellent job helping the folks that they are funding do this type of networking together.
We're still kind of working out a system in Oklahoma. We're still working on, we have a coalition of food as medicine practitioners across the state. We have 130 something members on that across 50 organizations. We just instituted managed care about a year ago. So we don't have some of these pathways. We do ask people if they're in other programs, like the woman who lost 132 pounds. She was also, in full transparency, in an exercise program. There are other programs in the area, but there's really a lack of resources in Oklahoma in its entirety. And so, you know, if a program is just giving them like 2 boxes of food bank food and that's the entirety of the program, I don't really see it as duplicity. I see it as wraparound services. And so whatever it takes to get them to achieve those outcomes, we are very careful around, like, do people to try to duplicate just in our own program of like signing up for delivery and then showing up to get food, and we make sure that we don't do those things. So we'd love to collaborate more. We've built a system to make it easier to source local food. So if Meals on Wheels wanted to do that or other programs, we would love to see that happen. I think not everybody is aligned in the same lane. So there's some people that are very much focused on food insecurity, and pounds of food is how they measure outcomes. We're looking at health outcomes. And so it is a little bit of a different lane. And so we still want our participants, if they need to go get food from the food bank or food pantries, but also be engaging in our program as their healthcare intervention.
And just quickly, we've directly collaborated with Meals on Wheels with the idea that they can stipulate the volume of food because they're addressing hunger and food insecurity, and we can still measure overall nutritional quality and work together so we address both outcomes, make sure that hungry people have enough to eat, but also standardize the quality of the meals and the quality of the dietary goals so we are elevating health.
So,
Can I just add 2 more things?
oh yeah,
So
sure.
as a systems change organization, we understand that that my work has been going over 10 years, right? I've been doing this work for 30 years. So as we continue to work in systems and food systems, don't give up on your farmers if you're trying to work with them. Systems change takes time. You go 3 steps forward and maybe 2 steps back, but just be persistent, and be positive, and remember that we're all trying to work on the same goals for the most part, and we have a more commonality than we don't. So don't give up on those farmers. Keep trying. It does work. It just takes time. Systems change takes way more time than we even want to acknowledge sometimes.
So just one quick question about, you all talk about fresh foods, which are wonderful, but as you know, is that oftentimes those go bad and they get quickly. Getting fresh foods, people, and one advantage is to frozen foods is that's one of the advantages. Where does frozen foods, especially frozen fruits and vegetables, which I know are not available for all fruits and vegetables, of course, but where does frozen foods fit into all of your work, if at all?
Yeah, I can answer quickly. A lot of the
Right.
programs we support, Craig, especially produce prescription programs, some of them are fresh food only, but a lot of them also cover frozen or certain kinds of canned fruits and vegetables. So usually they're
Yeah.
focused on produce, but the form is flexible. So, we were talking earlier about local food and seasonality. Like, of course, not every region's going to have local food in all seasons or maybe at all. So
Right.
I think that's particularly important to think about how to address that. So many of the programs we support do include frozen and sometimes
Okay.
canned.
Okay.
Craig, you raised the point earlier about the benefits of maintaining a global food supply and global distribution of food. And
Right.
of course, one of the ways to preserve the nutritional quality of foods is to flash freeze them right near the point of
Right.
harvesting. And in fact, if you flash freeze and transport that way, you can wind up with food of higher nutritional density, higher nutritional quality than if you source food that is not frozen but travels a while. You have degradation of nutrient content. So depending on the particular food in question, I think it absolutely can be part of the solution.
Yeah. Great.
In Michigan, we are fortunate to have Michigan Farm to Freezer. So that is, a farm distribution company that works on flash freezing, like Dr. Katz mentioned. And we have been working really, really closely with Michigan Farm to Freezer, not only to get our local legumes and fruits and vegetables into schools for our 10 cents a meal policy work, but also repackaging and redistributing those frozen foods through our emergency food provider system. So big fan of frozen, and also canned food we use all the time. I think I mentioned we use canned peaches in our peach salsa that we were making that we got from the food pantry.
Okay, great. So one of the key issues in all of this, and some of you have, David alluded to this and others, is about this notion about trying to introduce new foods to children and teens. And this is a question that was posed with Elizabeth Wilkin with respect to how do you do this? And one of the challenges, at least that I've seen in the context of vulnerable households, is that, it's easy for those of us with sufficient incomes as professors or whatever to if our children don't like something, well, they don't like it, we'll move on. And maybe we'll try a few times. People say if you give a child food 10 times, then they'll eat it. But one of the challenges with a vulnerable family at risk of food insecurity, they don't have that luxury of being able to say to a child, oh, you don't like it, you're going to eat it. It's a more difficult challenge for them. I think we should, and you all do recognize this. So I just want to pose the question posed by Elizabeth Wilkin. How do you direct children and teens towards more healthy foods at each daily meal? And I guess I would also add to that is, how do you do this in households whereby people have very limited budgets and they can't make a mistake with their food budgeting?
I can start.
Kevin?
I think
Yeah.
if we're going to talk about nutrition and kids, we have to talk about the school meal program in this country and the fact that we need to support healthier school meals. I happen to live in a district that has fantastic fresh cooked school meals, and my kids love it and eat it every day, and they get exposed to a lot of foods that way, Craig. And you'll find that if your kids eat food around their friends, they're more likely to try new things in a lot of ways than at home. But most parts of the country, or some parts of the country, don't have the benefit of scratch cooked meals in schools. It's a program that reaches something like 30 million kids every year. It's the largest equivalent restaurant chain in the country, and it's incredibly under-resourced, both in kind of like the price per meal that schools receive, but also we've moved away over the years from schools having kitchens or even having a regional hub that can prepare food. And so we're sort of been forced into a situation where we're largely serving processed or kind of frozen or pre-made foods in many of our schools. So I think that is a tremendously important program, especially for low-income families. There are families that participate in free and reduced lunch and breakfast in this country where their kids are getting the majority of their calories at school. So I just want to lift up that as a program that I think has a ton of potential to help to shift both kids' eating experiences and their diet quality, but has really been kind of underinvested in over the years and needs more support. And then maybe I'll just say more broadly, because I think this is coming up. Craig, you mentioned that there are states that are starting to pass legislation and sort of make other announcements, including around school meals, and trying to restrict certain ingredients and additives in school meals and sort of take those ingredients out, which I think is a positive thing. Like we should take some of those unneeded things out of school meals, but we have to couple it with like additional support and funding and incentives for the good options. I think if we continue to pass things that are just about restricting the bad, we will find a missed opportunity in terms of being able to introduce like healthier foods, fresher foods, whole foods, again, scratch cooking, those kinds of things. So one thing I do worry about a little bit in the moment we're in is there's a lot of energy around like restricting the bad things, which can be helpful, but I would love to see more support and funding and policymaking around increasing incentives for healthy foods, around the additional dollars that schools might need to adjust to those new policies and be able to replace those bad ingredients with healthy ingredients. I think we need support on that side of the equation as well.
Amen to that. As an equestrian, here's to the carrot, and withhold the stick whenever possible. And my horses would agree. So a few quick comments. First, I was, when I was editor-in-chief of the peer-reviewed journal Childhood Obesity, I talked a lot about the fact that we really shouldn't be talking about children in isolation. We should be using the word family all the time, right? Because this is one of those areas where children will do what they see, what they're exposed to. So we really want to be helping households eat better. And if that culture respects the value of good food for good health, and that becomes the culture that children grow up in, this becomes a family value. It's easy to start shaping taste preference very early. Taste preference begins to develop in utero, actually. Via the placenta, children are exposed to taste differences because of compounds in maternal circulation, and they're further exposed during breastfeeding. And there are studies that show that there are significant variations in neonatal food preference based on the maternal diet. So as parents eat, in particular mom, so goes taste preference in children. Also important to note that you can trade up the quality of your foods without spending more money. We did some research in this area as well. There are a lot of more nutritious food options in every aisle of the supermarket, for instance, that don't cost more money. It's just that people don't have the food label literacy to identify which are the more nutritious ones that don't. And then lastly, we developed a free food label literacy program for kids in elementary school called Nutrition Detectives. And we deployed this around the country. We studied it, and we published the results, Journal of School Health. So again, for those interested in the peer-reviewed literature, but we found that we could teach 8 and 9-year-olds both how to identify more nutritious food and why they should care, and really shape their behavior. And then they took it home and started to influence their parents. And then the last thing I'll say is just a shout out for taste bud rehab. Again, taste buds are adaptable. So you can have a conversation with kids at any given age and talk about, we love one another. We want to help one another be as healthy as possible because healthy people have more fun. You can frame the conversation whatever way as a parent you think is going to work best depending on the age of your kids. But let's support one another to be healthy, and let's do this together. And let's take a few weeks to start trading up some of the foods we buy, and let's give it a chance, because people can love food that loves them back, but it takes a little while to transition. If you're not eating a high quality diet, you have to learn to prefer those more wholesome foods, but that can be done, and kids can be engaged in that process. We've done some studies to show that.
Okay. We have all of you. So at the outset of this, I talked about the Trump administration really has transformed. I mean, there's been things done by previous administrations in terms of food as medicine, but at least, maybe back in the Johnson administration, there was a lot of talk about this or something, but at least so far as I've been following a lot of these, this is the time when the most proposals have been put forth by the Trump administration, but also by Republican legislatures. I mean, Devin, you just talked about how a lot of these states, along with putting restrictions on SNAP, a lot of red states are also proposing to put restrictions on school meals. So in terms of your own work, where do you see some of the initiatives of the Trump administration, and for that matter, in red states, which seem to be taking the lead on a lot of these, is what are you most excited about? What would be some things that you'd be like, how can we add things on, as Devin just mentioned some of those? So if you could talk a little bit about some of these policies, the MAHA, as Aaron mentioned, they're part of the MAHA movement. And so just some of the thoughts you had on opportunities for food as medicine in the new administration. Maybe that's a controversial topic, but anyway, I think it's something that we should be discussing, because really it is a major change from the past, for better or for worse. I mean, a lot of people especially those on the anti-hunger side, are a little bit not so happy about this. Other people are happy about it. It kind of depends. David or Aaron. Aaron, I'm sorry. Aaron, you go first. Aaron.
Yeah, I think there's a lot of excitement. It's a lot of good initiative being focused around chronic disease that we desperately need. It's definitely helped. Like, our bill in Oklahoma went through 5 unanimous votes. It's something we all agree on. I think we desperately need something we can unify on. Like David said, everybody knows someone who's ill. And we, in our loved ones, and we see what I saw as a young person is all this unnecessary suffering going on. There's necessary suffering of the lifespan, like birthing a baby, but you don't have to have chronic disease. And so I am very excited. I think there's some actions that have been a little not aligned with what they've said. They have certainly paused all the GusNet produce prescription funding that we receive. So we're out here achieving MAHA goals, but we are facing funding gaps that are serious, that are stalling this momentum that we have. And so I understand they want to rebrand certain programs, and they certainly want to ensure that these funds are going to farmers and different other programs, and maybe rename certain programs. So I'm anxiously awaiting to see them put their money where their mouth is on these things.
Yeah.
Thank you, Aaron. I'll just tag on that, we've seen great success with our local food purchasing assistance. So that's something that we would really encourage the administration to think about. And, the nutrition incentive programs in the Farm Bill, GusNIP in particular, all of that needs to be bolstered and supported. We have a beautiful policy program, our 10 cents a meal for school kids and farms. Michigan is already reimbursing for school districts to buy local produce and legumes that are Michigan grown, and also the diabetes prevention program, as Dr. Katz mentioned. It's been a remarkable program. We use the diabetes prevention program as a way to get our physicians to refer patients. And then we also use a lot of those materials to educate the physicians themselves. Requiring physicians to have nutrition education would be a tremendous step in schools, in med school, and perhaps doing a residency program that specifically is geared towards family practice and nutrition, aligned with College of Lifestyle Medicine. Our family practice physician is paying for their medical residents at Michigan State University to become certified in lifestyle medicine. So we're just, adding on to that with our culinary medicine and the teaching kitchen program.
Okay.
The only thing I would say is that when we talk about implementation, it's always predicated on what we know. What we do is rooted in what we know, and what we know comes from the effort to learn new things, advance understanding, which in turn depends on evidence and science. So simply a plea that across the spectrum of perspectives, ideology, politics, we recognize the value of biomedical research in this country, and that needs to be part of the formula. I have colleagues involved in programs at the NIH and various universities directly related to advancing food as medicine, whose work has actually been disrupted, and we need that as part of the formula. So we have to recognize the value of that generating evidence is the foundation for understanding, and we have to know what to do before we can do much of anything. And then, Craig, I obviously am happy to applaud the opportunities as they arise, but I agree. I think, the proof will be in the pudding. We need to see effective implementation and scaling, and most of what we're seeing is budgets being constrained, and the focus on deregulation with talk about regulating the food industry and the food supply in ways that haven't been done before. So we'll see how it all plays out, but hopeful.
Yeah, great. So Devin, we have just a couple minutes left before I have to turn this back over to Morgan for some concluding remarks. Do you have anything you want to say with respect to this question?
I mean, I think in terms of this administration, like I said, I'm encouraged by the focus on dietary health and the role that food and nutrition plays in health, and that it should be an area of interest for the Department of Health and Human Services and for other, health system stakeholders.
Yeah.
I think, to my earlier comment, I'd love to see more investment in expanding access to healthy food, in addition to some of the restrictions that are coming out around unhealthy food, and make sure that, to Erin's point, kind of the policy and the funding also supports the increase in access to healthy foods. That's really where my eyes as we go into the next months and years.
Okay, fantastic. Well, I wanted to thank you all so much. This was great. We had a lot of questions from the audience, a great audience participation, which is always wonderful to see. So I wanted to personally thank all of you. I wanted to thank everybody in the audience for joining us today. And I want to thank Morgan, and then also Tim Brennan for organizing all of this. Really appreciate that. So I'm going to turn it back over to you, Morgan, for your closing remarks. Right at 10:57.
Thanks, Craig. What a robust discussion we had on this forum today. Really, truly, lots of different perspectives and also alignment. It was just great to have you all here. So we have several more forums planned throughout the rest of the year. So please be sure to mark your calendars for our next forum on June 25th. We'll be diving into reviving rural agriculture as the heartbeat of healthy communities, a conversation we're proud to host in partnership with American Farmland Trust. And with that, I just want to again thank our panel for this wonderful discussion today. I'd also like to thank all of you in the audience for joining us and submitting your questions. We appreciate your engagement with us and would love to hear more of your feedback. So please do take a moment to take that survey and share your comments about today's session so that we can continue to improve and on these forums and make them the best that they can be. Also, if you'd like to help us continue to provide these valuable programmings, you can become a friend of Farm Foundation. So I just want to remind you that that's also an option today. You can click on the link that was in the chat, and each and every gift for the foundation strengthens our ability to address the rapidly evolving issues impacting agriculture and the food system, as well as our rural communities. So we are so grateful for your support and ecstatic that you all have chosen to join us this morning. Again, thank you all so much, and I hope you have a wonderful rest of your day.